I did say that I had the opportunity to bring a stellar cast today, and I'd like to introduce my colleague and friend, Denise Farmer. Denise and I work on the Health and Justice Clinical Reference Group, and Denise has been an absolute trailblazer in terms of ensuring that some of the best practice, the consensus work that we've been doing is written down into accessible and constructive guidance documents. And I have to say that Denise has been a driving force in some of this, particularly around pain management, which some of you in the room will have worked with Denise on, those standards, and are now putting those standards into practice. But more recently, in some guidelines that we were really keen to have out there around mental health prescribing. And of course, when we talk about dependence-forming medications, obviously we think about gabapentinoids, obviously we talk about oral painkillers, but we also need to be thinking about mental health medicines as well. So Denise, thank you very much for taking us through those standards and guidelines.
Thanks very much. It's really nice to be with a gathering of, I hope, like-minded people trying to understand and share practice with the challenges that you face on a day-to-day basis. And I don't have to face them. What I get is the information from all of you about how difficult it is. And with NHS England Health and Justice Commissioning, we are trying to adapt the guidance and publish guidance, also looking at how we commission services in order to make it easier for you to deliver the safer care and meet the challenges that you face. So what I've been asked to do today, which I hope isn't going to be too dry a presentation for you, is just to give you a whistle-stop tour of some of the guidance that is out there that you can use to support some of the statements that you can make to your patients, some of your own personal development, some of the information that you need to make those prescribing choices that are safer within the secure environments. So that's my task for today. What I'm going to do is just to remind you about medicines optimisation in health and justice, some of the key information that I share with everybody when I talk about our sector, some of the overarching guidance and standards for prescribing safely, the pain management information that we've published, and the mental health publication. And there's a little bit more detail about those, just to remind you or to signpost those to you if you haven't heard about them before. So what is it that I do? Well, sometimes I wonder, but actually I am the strategic lead within NHS England to try and make sure that we have medicines optimised for people in health and justice. And what does that mean? That means that the right patients get the right choice of medicine at the right time. It actually focuses on outcomes and patients. And the concept of medicines optimisation was first published by the Royal Pharmaceutical Society back in 2013, and subsequently we've had some nice guidelines associated with that as well. And it talks about 4 principles and 7 elements which describe what medicines optimisation actually is. More recently, in this year, in February, there was the Medication Without Harm WHO Challenge, where we're looking to reduce over the next 5 years harm from medication errors by 50% globally. And there's a whole tranche of work coming out through NHS England about how we're going to achieve that. One of the things that I'm going to be doing is to try and interpret that for health and justice so that we can equally demonstrate our achievement of that challenge. And finally, we had the publication by the Royal Pharmaceutical Society of professional standards for optimising medicines for people in secure environments, and that's what we now commission NHS England. It describes that medicines pathway and the standards expected by providers in order to try and optimise medicines for people in health and justice as well. And we're really pleased that that has given a foundation for what good looks like in terms of that medicines pathway. I use this slide everywhere. I've used it for donkey's years. And because we always struggle in the community with the primary to secondary care interface, don't we? Can we get that right with medicines? No, we can't. This is ours. So if we have got all those different transfer of care issues, that pathway is complicated. However, we have to make sure that people who need a medication clinically are able to access that safely and continually, irrespective of where they happen to be and irrespective of where they're going and where they end up. And that is one of our biggest challenges, is that continuity of medicines. And that creates some of the risks and issues that Tim has already alluded to about omitted doses and delayed doses when people come into our system from the community, where that is the highest risk and challenge that we face, or you face, in terms of accessing the medicine somebody needs promptly, but also having the safeguards that say actually they shouldn't be on this, or they're not actually on it. And we have the usual medicines pathway within health and justice, looking at prescribing, dispensing, the supply and administration of medicines, and wastage and storage. That pathway is exactly the same. It doesn't matter whether you're at home, in the community, whether you're in a hospital, whether you're in a mental health hospital, wherever you are, that is what the medicines pathway is. But for us, it's the in possession and self-administration bit. It's this bit that we have the difficulties with, and also about the prescribing choices that we need to adapt in order to make sure that our formularies and the medicines that are being chosen are safe in the environment, in the secure environment. So that is common in all sectors, but we have our nuances, don't we, in terms of keeping that effective and safe. And Tim alluded to the partnership that we have to have between healthcare provision and our prison partners in order to enable people to access their medicines in a timely fashion. And I've always described it as a Venn diagram, and there's a lot of joint working that's needed in order to make sure the person can be available to receive their medicine at the right time, 7 days a week, whether that's under supervision or whether they have that medication in their possession. These are the risks that we have within the medicines pathway. We know all about those, I'm not going to dwell on those. And we mustn't forget that we have an increasing, capable and effective pharmacy workforce working in many of our prisons. I've been doing this for 15 years, working regionally and working nationally over the last 4 years. And I have to say, if I was to have taken a photograph of the state of the system when I first started compared to the pharmacy workforce and the state of the medicines cupboards and everything else, it would be a revolution. And I think we have to remember that you have that increasing support, that we expect that to have some equivalence to community pharmacy services, and increasingly the clinical pharmacy services that are provided now within GP practices. We're moving towards developing that model within our services, and those right systems and processes that are essential to underpin that safety of care. And we have that range of workforce with an absolutely fantastic set of skills and knowledge. So for goodness sake, use them. And if you haven't got enough of them, get more. So, in terms of the guidance that's out there, we've got some overarching prescribing guidance. And I went to this for the first time for about 3 or 4 years. And this is the landing page of that website for those. And I thought it was useful to just pick out those phrases on the right-hand side, because I was quite surprised to see them, because it's in your face on that website. But this is what prescribers are doing all the time. These are the decisions, and we mustn't forget that this is the expectation. Then we have the competency framework, which is the competency framework for all prescribers, medical and non-medical, and that's published by the Royal Pharmaceutical Society, and that goes into a lot more detail about the kind of skills that prescribers need in order to prescribe safely. We have our good friend, Safer Prescribing in Prisons, which is currently under review, and we're expecting it to be published in November 2018 by the RCGP-SEG. It's work ongoing, and hopefully there'll be information about that shortly. Now, pain management within health and justice, we decided we needed bespoke guidance back in 2014. That was one of the first things they asked me to do. They said, we want a prison formulary for everything. I said, well, I don't think we need it for everything. Where do we need it most? And it was decided that pain was where we had the most issues. And so we developed some bespoke guidance to support you in making those choices based on the demand risk and diversion risk and other comorbidities of people in our sector. NHS England, we collaborated very widely with experts, and many of you are in the room today, and we developed the formulary using nice guidance about how to develop formularies. So we had a good foundation about how we achieved that, and we refreshed it in 2017. The pain formulary looks at acute and persistent pain and neuropathic pain. It doesn't include palliative care and specific pain management conditions such as migraine or rheumatism, etc. It has a RAG rated key to highlight suitability of risk in health and justice, and it summarises the key clinical evidence and signposts people to published guidance. And there's an implementation guide, because a formulary is a list of medicines at the end of the day. It's about how you make the choices and some of the considerations you need to make when making those choices and deciding whether to prescribe in the first place that's important. So the implementation guide was developed so that they gave you an idea of sort of, that was the what, the pain formulary was the what, and the implementation guide was the how. And to supplement that, within that implementation guide, we included the scope and development of the formulary, how you fit the medicines into the pain pathway, the patient's perspective. We were very lucky that we were able to speak with patients to get their views about their experiences of receiving and having their pain medicines reviewed, and some of the anecdotes that was in there will be very familiar to you about that. It describes prescribing, reviewing and continuing pain care, self-care and supporting self-management of pain, because a lot of prisons will enable people to access paracetamol and ibuprofen just as through protocols. So that enables people to get that minor ailment prescribing from medicines for minor ailments, from a more accessible source, rather than having to see a prescriber in order to obtain those. And also about how to optimise safety when prescribing and using pain medicines for people in prison. We collaborated with the specialist pharmacy services to try and access some information from many of you about how you then implemented those elements within the implementation guide. So this is a resource that is still available that has got embedded protocols and shared care guidelines and various other strategies and information about compacts, for example, around pain medicines. So that document is available as part of the suite of documents relating to the formulary that you can use in order to give you ideas about how you can change the way that you manage people's pain medicines. In addition, I hope everybody knows about Opioids Aware. Are you all aware of Opioids Aware? It's a fantastic website. For those of you that haven't seen it, it's a great resource that brings everything together. Before that was available, Linda and I did a presentation when we launched the pain formulary back in 2015, and I had a slide with about 10 different pieces of evidence on it, and there was loads of resources all over the place. This has brought it all together in one place, and those key messages, we use those a lot to try and get those messages out, because they're the 5 things that you can do, 5 messages that you need to have in your mind all the time when thinking about opioid prescribing. And there is a momentum in the wider community, in CCGs and in primary care more widely, and to a certain extent secondary care, about the issues that we have with the amount of prescribing of opioids within England, and also the gabapentin and pregabalin as well. So there is much more going on, and the WHO Challenge will give us an additional opportunity to drive this agenda forward. So we're trailblazers for that, because we've covered a lot of that ourselves. So additional resources for pain. We have got this persistent pain guidance. And then finally, the Health and Justice Mental Health Service, Safer Use of Mental Health Medicines. That was published in September. It was a route to publication through a similar approach using a task and finish group chaired by Dr. Nick Koski. That published 10 principles around safer prescribing of mental health medicines. And we were able to cover continuation, advice on diversion and risk, prescribing responsibilities and shared care between mental health specialists and prescribers, general practitioners, patient information to help them. One of the issues about people going on the net might be that they haven't been told that they don't need to worry that they're not going to get their antidepressant for a couple of days, that it's fine, and that they will be getting it, but we just have to verify the dose to keep them safe. Or we just want to see how you are for a couple of days before we actually start prescribing something else that will make you drowsy. So there are other resources around mental health, and that's the Standards for Prison Mental Health Services, which is a very useful document as well, and that goes alongside the prescribing of the medication. And there's, of course, NICE guidance. So I've reminded you about medicines optimisation. I described a whistle-stop tour, and that's what it's been. Hopefully, if you Google any of those titles of those documents, you'll be able to find them easily. I checked, and you still can. So hopefully those kind of publications, of which there are many more now relating to our own sector, which 4 or 5 years ago they were not, hopefully they do give you some references to use in order to support your prescribing activity. Thank you very much.